introducing our webinar participants. You won't see them, but we've got quite a few people from all over WA that are actually listening and watching in on us today. My name's Juliana Summers, and I'm a project officer on our fall prevention programs here at ICLA. To start with, we'd like to respectfully acknowledge the past and present traditional carers of this land on which we are meeting, the Noongar people. It's a privilege to be standing on Whadjuk country in the Noongar land. We also acknowledge the contributions made by Aboriginal Australians and non-Aboriginal Australians to the health and wellbeing of all people in this country. So before we begin, we're just going to do a bit of housekeeping. So the registration is just at the door. If you haven't done it yet, if you can just do it on your way out. Emergency exits are at the back of the room and to the left here. The toilets, you would have passed them coming in. So if you just go back out to the main entrance and they're on your left. Parking, is anyone parked in the City West Lottery's house space? That's fine. And also we'll be taking photos and the video today. Is everyone okay with that? If you have any issues, if you just come and let me know at the end. And lunch, if you haven't had anything, it's just at the back, so feel free to help yourself. So the ICLA Lunch and Learn forums have been happening for a few years now. We use it as an opportunity to help you, to benefit the people that can attend. We organise the forums as an additional service to health professionals, and we also invite the community. They benefit from income generated through memberships, and we do have membership forms just at the front there. And our next Lunch and Learn will be on Thursday, the 2nd of August. Alright, so today's Lunch and Learn forum is on Mordich Jenner, which means strong feet. It's a podiatry and diabetes education service for Aboriginal and Torres Strait Islander people in the Perth metropolitan area. It's part of the National Close the Gap initiative, and it's been developed with the primary aim of increasing access to the podiatry and diabetes services, which are culturally secure for Aboriginal and Torres Strait Islander people. Mordich Jenner aims to help the community keep their feet healthy and strong, especially those that are at high risk of foot complications as a result of chronic disease. We're pleased to have Maureen Unsworth and Doreen Turvey presenting for you today, which are these lovely ladies here. So Maureen Unsworth, who is the first one here, she's a registered nurse, a midwife, and a credentialed diabetes educator with a long history of working with the Aboriginal community. She's currently managing the Mordich Jenner program for the South Metropolitan Area Health Service. And behind Maureen is Doreen Turvey. She's an Aboriginal health officer, also working for the South Metropolitan Area Health Service. She's an Aboriginal health professional and diabetes educator, and she has a long history of working in health. If you can just welcome them, and they'll be here.
Thank you, Juliana, for your kind presentation and for inviting us to present the Mordich Jenner program. I'm Maureen, this is Doreen. This is Maureen, this is Doreen. We even share the same birthday, so we're so we're two of the members of the Mordich Jenner program. And as Juliana said, this is a COAG funded program, which means at the moment it's actually funded till July 2013. July 2013. We are pretty sure that it will continue to be funded post 2013, but we're not sure about that. It did actually start earlier than the COAG funding. It started in 2009 when we were starting the District Aboriginal Health Action Groups in the South Metro Area Health Service, where we were consulting with the community, and podiatry and diabetes was a priority health issue identified by most of the District Aboriginal Health Action Groups. So it has actually been endorsed as a program that's a priority area from the community, and that's where we wanted it to start. When we look at why we actually need to actually have this service, as we know, the burden of disease for Aboriginal people is much higher than non-Aboriginal Australians. It's listed as 2.5 times higher than other Australians. And in our South Metropolitan Area Health Service, we have 15,000 Aboriginal people. It's the second largest Aboriginal population in Western Australia, next to the Kimberleys. We have 5 health districts, with the Armidale area having the highest population of Aboriginal people. But even the smallest population of Serpentine, 400 Aboriginal people, we have significant population of Aboriginal people living in our area. And we also know it is improving, and there's been a lot of improvements in Aboriginal health in recent years. But in fact, life expectancy is still 13 years less than the rest of Australians, mainly due to the burden of chronic disease, like diabetes, heart disease, COPD, etc. And the diagnosis of diabetes occurs at a much younger age. We have Aboriginal people as young as 10 being diagnosed with type 2 diabetes under the care of PMH. And they access services a lot less than the rest of the population. In fact, we know that they access essential primary health services and secondary services 80% less than the rest of the population, which is an indication that we do need to do things differently. The services are needed, but the services needed to be delivered in a way that was culturally appropriate for Aboriginal people. Diabetes is, if you look at an Aboriginal person that's 40, 45% of them will already be diagnosed with type 2 diabetes, whereas in our non-Aboriginal population, we start to screen for undiagnosed type 2 diabetes at the age of 55. But for Aboriginal people, we screen from the age of 18 because of the early onset of type 2 diabetes. We also know that the complications are developed much earlier, and quite often a person with diabetes will have up to 5 comorbidities as well as their diabetes. And in a Western Australian research published recently, Aboriginal people are 38 times more likely to have a below-knee amputation by the age of 49, which is really high.
That is high, and also overall with amputations, it's usually about 98% of Aboriginal people with amputations due to diabetes and its complications. Yeah, and that's a very high figure, you know, that's scary, and I guess that's why we really need this program.
And when it comes to why do Aboriginal people not engage with our mainstream health services, it's for many, many reasons. But for a lot of it is because they've actually had a traumatic experience with mainstream services. But there are other reasons like transport and
some of the other barriers that stop people from self-managing or looking after themselves or looking after their conditions. Whereas where the podiatrists are, I don't know if Angela, what about podiatrists who may be listening, whether she wants to come online. But to add to what we're saying, as part of our team, we've got 2 podiatrists, and yeah, we really work in well together as a team. We're only a small team, but it really does work, and I'll go on to explain after the assessments.
When this proposal was put up to the Aboriginal community as part of one of the COAC funded programs, it was actually titled a different name. It was titled Podiatry and Nutrition Outreach Services. And from the very beginning, the community actually, even though nutrition is important, we all know that, they actually identified diabetes as their most serious health issue, which is why we changed the staffing configuration to podiatry and diabetes ed. And we actually refer to other health disciplines like the dietitians, social workers, physiotherapists, occupational therapists in mainstream services. So we're not about actually duplicating any services, we're about also improving people's access to service. But when
working in partnership.
And working in partnership, yeah. So our initial focus was to really identify high-risk foot problems and amputation. because a lot of people actually remain undiagnosed with quite serious complications in the community. We also wanted to improve Aboriginal people's access to routine podiatry care. We know that everyone with a high-risk foot problem or diabetes should be screened on an annual basis, and in some areas with the Aboriginal community they say every 6 months because things go wrong fairly quickly for some Aboriginal people. So we wanted regular screening, and none of our clients are actually discharged. They're on a system where we can actually flag them to come back for their regular 6-month screening to ensure that things don't happen that is going to decrease their health status. Yeah.
That's right. There's no 3 strikes and you're out, 3 DNAs and you're out. We just hang on to the clients and do reviews, follow up with reviews.
And we're very lucky that we actually have, most of our staff are Aboriginal, and Dory is our most senior Aboriginal health professional who actually has the diabetes education qualification. But we've also got Susie Bonney and Michelle Michael, and they know their community, they know their networks, and they know their families. So we actually can follow up Aboriginal people through the Aboriginal networks that tend to be in mainstream actually fall through the crack quite often. But we also want to actually make sure that we put in diabetes education and management of foot problems and strategies to ensure that we prevent amputations. Where possible, we work in partnership with organisations like Multidisciplinary Wound Clinics, Silver Chain, Wounds West, other specialty services, and we don't want to duplicate the gap, but we also want to actually influence mainstream services so that they actually start to provide these services a little bit more culturally appropriate for Aboriginal people. It's not about changing the content of what services they provide. It's about changing the process and how they actually address and develop rapport and win back the trust that's been lost by Aboriginal people with our mainstream health services. So what we're really about is closing the gap, not duplicating any services. So we actually aim, as our first priority, top one off the list, is to make sure that our service is culturally appropriate. So even when it came to recruiting our staff, we actually had Aboriginal elders who were trained in HR process to sit on the panel and be part of selection process for our staff. Wherever possible, we actually employed Aboriginal people with the qualifications because that's the most culturally appropriate way to have our workforce that is actually one of the community to actually ensure that Aboriginal people trust and develop a rapport and the service is respectful and appropriate.
And that was really good because it really worked having an Aboriginal community member come in and sit on the panel, and they're likely to pick the right person for that job, or they think, who would be able to, work in with, engage with the community, work in with them, and that was really good. Just being able to put that in place.
Our service delivery model is quite different, and that was at the request of the Aboriginal community. Access was a main criteria for how the service was to actually be.
Stop the webcam, Juliana.
Yes, I'll press something. Yeah, how the service was to actually be delivered. So in the first instance, we're a duplicate of the service in North Metro Area Health Service too. So the North Metro Area Health Service and South Metro Area Health Service have their own teams and their own podiatry vans and their own bases, but wherever possible we work together and there is a steering committee to guide that with Aboriginal health professionals on that steering committee. Because we want to actually make sure that the population across the metropolitan area, which is virtually the same needs up for North Metro Area Health Service and South Metro Area Health Service, is duplicated, and we work together to make sure the service is actually, we're learning from one another as well, from the experiences that they've actually come across in the north. Sometimes we learn from that, and likewise with the south team, when we share with our experience from the south, they actually learn from us, and we share resources, and that's actually reduced the cost of developing the services by having not duplicating anything. Even our promotional pamphlet is the same. But our podiatry service actually goes out, and you'll see the map shortly, to 10 sites now. 6 of those are from a podiatry van that's been purposely fitted out as a podiatry clinic where we couldn't partner up with an existing service. And the others are partners with Aboriginal organisations that already provide services for Aboriginal people, and that we wanted to, one of the wishes right at the initial consultation was a one-stop shop. Aboriginal people wanted to come to one place for all their services. So we've actually, even though in some areas we have, from the COAG funding, have actually implemented purposely built or acquired one-stop shops for Aboriginal community where all health services are run, like the Woolwich Court in Kwinana and the Nidjalawanga Maya down in Mandurah. And they are 2 of the partners that we go once a week and add to their service. So when we've partnered with an existing organisation in a local area, we actually want to actually link with existing networks there, so that when we're not there, the service continuity can continue. So the service delivery model is quite hard in that we operate from one base in Kelmscott, and we have to travel to our clinics every day. And with our equipment as well, because our partners actually don't have space in their services for our equipment, so we actually pack our cars up and our vans up and travel to site and have the clinic from 10 to 3, and then pack up and come home and sterilise our equipment and do our data entry and catch up on our case management and follow up phone calls, etc. So it is quite intensive for our staff, and the travel is quite extensive. Initially, we thought we'd be perhaps focusing more on identifying and early intervention for high-risk foot problems, but as it is, just from last year's number of people who registered in our program, which was 318, 118 of those actually were categorised as high risk, that already had wounds, that already had infections, that already had amputations, that already had severe compromised neuropathy and devascularised legs, and other complications from diabetes as well. On dialysis, and a lot of our case coordination is actually supporting our clients to access other levels of care that they need to for the essential services that they're missing out on. Diabetes self-management education was a really important area for Doreen to work on, but what we're finding is that she's really having to concentrate on diabetes management in the first instance. Yeah. And so many of them have uncontrolled diabetes or on wacky treatment regimes that need to be worked out.
So the first thing is to do a diabetes assessment, and it's a really good comprehensive assessment, which just to be able to, for people to manage their diabetes, you've got to work through the barriers first, just I guess working with people and supporting people and teaching people how to self-manage, and trying to get help or support for any issues that are stopping people from managing. That's where our we've got a comprehensive assessment tool that we use. Our Aboriginal health professional Susie or myself will do the initial assessment, and where that initial assessment is concerned is where all the areas, the social health things are usually identified, which is really good. So when we first see a client, that initial assessment, is vital, because self-manage when everything else is going on. And then they'll have the diabetes assessment, and you do the biometrics as well, and then podiatry assessment. So yeah, it really is a comprehensive, really quality service that we're providing out in the community. And I guess we've hit the road running. You know, like Maureen said, we're flat out doing clinics from Tuesday to Thursday. We're at different clinics all the time. I actually go to 9 clinics for myself as well a fortnight. So we're flat out. Sorry?
Oh, no,
Fortnight. Yeah, it's like with the Kelmscott, that's our Monday clinic, so we're at our base. The rest are off-site, so yeah, flat out, like Maureen said, loading our equipment.